Special needs or special medical and dental needs means, so these are patients who have some specific limitations which you have to address when you are practicing in radiology in or in all the aspects of dental assistance. So you can meet with vision impairment patient in which the patients are not able to see properly or have some problem with the vision, maybe a recent eye surgery or blindness. So in such kind of patients, you have to communicate with clear verbal explanations of what you are doing, and you have to always explain the procedure to this patient before doing the procedure. Hearing impairment patients. So, in such patients, you can ask the caregiver to act as an interpreter, use gestures because they are not blind, they can have only problem with the hearing, either reduced hearing or complete hearing loss. So, if the patient is educated, you can give written instructions to the patient as well. Sometimes you can take the help of gestures like making the patient seated and making the patient wear the lead apron. You can show it with the gestures how you are going to make the patient sit and the patient has to wear the lead apron. Or if the patient has an interpreter, then you can ask the interpreter to convey the message to the patient. So, if the patient can read the lips, that means the patient is used to reading the lips of the person whom he is talking to or she's talking to, then you can slightly lower the mask and face the patient, of course, with some distance, and speak clearly and slowly so that they can follow your lip movements and try to understand and correlate what you want to tell them. Next is mobility impairment patient, in which the patient is unable to walk. The patient might be on wheelchair. It can be a temporary or a permanent issue, but the thing that you have to take care is the patient cannot stand and move onto a dental chair to take the radiograph. So you might need to take the radiograph in the wheelchair itself. The second thing, you should not be asking about the disability to any of these patients. It's one of the important things that you have to always remember. You cannot ask a vision impairment patient that how did you lose your eyesight, or why did you do eye surgery. You cannot ask a hearing impairment patient that why did or how what is the reason for your hearing loss, or a mobility impairment patient that what kind of disease do you have which made you to be having this mobility impairment. So all these things you cannot ask the patient, and these personal questions should be always avoided. Even though if you want to build a good rapport with the patient, if the patient tells by themselves, it's okay, but you have to be a active listener in such a case without asking a question to the disability explained to you by the patient himself or herself. So always offer assistance to these patients. You can help them by pushing the wheelchair or directing the person who is blind. Often a blind person may prefer to hold your arm rather than wanting you to hold the patient's arm. So, as youngsters, you will always try to hold the elders' arms and direct them. But these patients, especially the blind people, they feel more confident when they hold their arms on your arms. So they will be holding you, and you will be allowed. You should be allowing them to, gently hold your arms and guide to the place that they are supposed to go. So do talk directly to the person with the disability, and it is always rude to talk to the caregiver instead of the patient unless you have some problem with the interpretation. So if it's a hearing impairment patient, you can lower the mask, keep the distance, and talk softly and slowly so that they can understand or and do the lip reading. mobility impairment patients also, you can inform the procedure as you do it for the vision impairment patient. So when you explain it and when you do it, you will be getting more patient comfort and rapport to get the imaging done without much issues. Again, always remember, anterior exposures should be done first, than the posterior exposures. For example, instead of asking the caregiver, can Mrs. Jonas get out of the wheelchair, you can speak directly to Mrs. Jonas that whether you can come out of the wheelchair and sit on the dental chair. So they want to be talked to directly rather than the use of a caregiver. So if they are able to follow you directly, always give direct instructions and build confidence in the patient. The next thing is about the dental need patient. So, dental needs patients can be edentulous patients or pediatric patients or endodontic patients. Okay, so edentulous patients, they don't have teeth. So, when you take the radiograph, you might have to use some extra support like a cotton roll. So for completely edentulous patients, you can use either of the techniques, bisecting or paralleling. Because there are no teeth present, the inherent distortion in the bisecting technique, which means the vertical or horizontal angulation errors, will not interfere with the diagnostic intra-bony, that means bone quality, or the details in the bone that we are going to look at. Because there is no teeth, there is no point of overlapping or elongation or shortening of the image. Okay, so these are the errors that occurs when you set the vertical and the horizontal angulation. Too much increase in vertical angulation, you get a shortened image, and too less vertical angulation, you get an elongated image. So these things are not applicable here in edentulous patients because there is no teeth, and this is not going to compromise the bone quality or the diagnostics that you need to get from the radiograph. But for the partially edentulous patients, when you want to keep the image receptor holding instruments, you can use the cotton roll on the bite block where the crown is missing. For example, mandibular first molar is missing. You want to take a paralleling technique, and then you are going to keep a cotton roll in the place of missing mandibular molar and then use the technique as normal, even if it's for by doing or bisecting angle technique, any of these technique. If one tooth is missing, keep a cotton roll and then you can use the holders to keep the or to expose the radiograph. If you are using a bisecting angle technique, in the case of a missing tooth, then you need not keep a cotton roll or on the holder. Okay, but this is applicable only with finger retention technique, where you place the film or the sensor and the patient is asked to hold the sensor or the film with the finger. If you're using a holder for bisecting technique or paralleling technique, whenever you use these holders or even the bite wing, you can place the cotton roll. That is the technique modification that you do for an edentulous patient, which is partially edentulous. Next is the pediatric patient. So pediatric patients always have a problem with the exposure if they are too young. So you must explain the patient the procedure in terms of the language which a child can understand. For example, you're going to take a photo of the teeth, so you're going to see how your teeth is, or how the teeth is happy or teeth is sad because you have a caries there. Something like that. You have to make the patient comfortable and agreeable to take the radiograph. So always use the language which the child can correlate to. Okay, if you ask the patient to just sit and open the mouth, he will reject the first radiograph itself. So you have to explain these things to the patient, how to sit without moving. You should not be moving when you're taking the photo, all these things. And also you have to explain that you will be going outside the room and you'll hear a small sound. That means your photo is taken. Else, when you go outside the room, the patient will also drop all the sensors and films and come out with you. Okay, so make sure that you know the patient what you want from them. The shorter exposure time in the control panel will also reduce the effect of blurring if at all the child moves during the exposure time. Okay, the exposure time is very less, so as soon as you come out, you can press it and then the exposure is done within very few seconds compared to the adult exposures. So in the primary dentition, you can see the full mouth radiograph with the occlusal radiographs made with size 2 films and the other radiographs with size 0. In pediatric patients, you can take occlusal radiographs for anterior teeth, but for adult patients, unless the patient has a disability or difficulty in opening the mouth, then you can take an occlusal instead of periapical. But in that case, the angulation that we give for adult radiograph instead of periapical, for example, you want to take a periapical view of central incisors in a patient who has fallen down and fractured the tooth. So when you take a periapical radiograph, you get actually the full length of the tooth almost accurately. But if you take the occlusal view, the teeth will be appearing shorter. So if you want to do a root canal treatment, in that case, you will be doing an under cleaning or under filling for this patient if you take an occlusal radiograph. That is why for the root canal and all those indications, we specifically take a periapical radiograph. So for children, because the tooth size and length is smaller, you can still manage with the occlusal views. In the mixed dentition, that is 7 to 12 years of age, you can also see the full mouth radiographic views with two bite wings on either side because there are smaller teeth, premolars may not be erupted, and this will help us get the whole segment of teeth. So 3 to 6 years, you need two occlusal views, two bite wings, and four posteriors. And for mixed dentition, where you have both primary and permanent teeth, you will need um, six anteriors, four posteriors, and two bite wings, all with the size 2 film. Okay, not with the pediatric films. Then patient with the special dental needs, we have the endodontic patient and the gagging patient. Endodontic patient, when you're using radiographic exposure in these patients, if it's a bisecting angle technique, you have to be careful that the files don't come out when you're inserting the films and asking the patient to hold the film or the sensor in the position. So you also have the green color positioning instrument. So in the area of the biting block region, instead of the bite block, you will have a small hole in between the bite block. Okay, so for example, for the periapical or the bisecting angle technique, the patient can bite on the bite block, whereas in the case of endodontic posturing device, there will be a central hole which will help to make the instruments come out of these holders. Okay, so which means that your endodontic file or reamer is going to be coming out from this hole like this. So there is no problem with the patient and you get more accurate image details. Okay, so the endodontic patient, the only difference in the holding device is the beam holding device or the beam alignment device with the positioner. The bite block will have a central hole so that it can give the space for these endodontic instruments and the filling material. So in the case of endodontic patients, minimum 5 millimeter of periapical bone should be visible and the images should be accurate without elongation, without foreshortening, or without overlapping because they're going to affect the treatment plan. Now, the last one is the gagging patient. So, to prevent a gag reflex, that means vomiting reflex, you have to always convey a confident attitude. That means you should be displaying confidence to your patient. So, if the patient senses nervousness, so if the patient tells you that in the previous dental visit when they took the radiograph, I had a severe gagging reflex. So, what you need to do is just listen and just acknowledge what they said, and you can tell them, don't worry about that, it will be handled. That's it. Okay, so you need not give any more details or ask any more details about the gagging. So this will create a psychological block, and the patient will be more anxious in taking the radiographs and may not be comfortable, and actually it can cause a gag reflex. So this will make the patient non-compliant to the radiographic exposures that you want to take. So what will you do in these patients? So in these patients, confidence of the operator is a very good thing that you can look into. Never ask the patient about the gag reflex. If you ask, the patient will have the psychological block. Reassure the patient that it's going to be handled, and you will be doing the images very quickly, and you'll not get any gag reflex. So the patient can feel embarrassed if he or she has a gag reflex when you place the sensor. So remain calm and in control, and make the patient also calm. Suggest breathing techniques. That is the first thing that you can do. Ask the patient to deep breathe through the nose. Of course, all of us, we are breathing through the nose, but when you ask the patient to breathe through the nose, the first thing which occurs is the patient's attention will be diverted through the to the breathing process. Second, when you are breathing, the gag reflex will actually stop. So when the gag reflex occurs, it means they're not breathing to the nose. So you have to instruct them to breathe through the nose and count till 20 or 30 depending upon your speed. So in this case, anterior exposures first, followed by the posterior exposures, as you do always. But the time which you position and take the image should be very quick, so that the gag reflex is not initiated. So you will be knowing about your skills and the time that you need to take the radiograph. So ask the patient to count till that time. If you are fast and you can take the radiograph in 5 seconds, place the sensor, ask the patient to breathe before placing the sensor until 10 seconds, because you can complete it in 5 seconds. Then come out and expose, and then you can instruct the patient before coming out. Once you hear the sound, you can immediately remove the sensor or the film. Then the other option is to distract the patient. You can instruct the patient to do one of the following process, like biting hard on the holder, or raise the leg in the air or arm in the air. That means just to slightly raise the egg also leg, so that they can get distracted. So this can also be achieved, but the breathing technique is much more better than the distraction technique. Reduce the tactile stimuli. That means give the patient an ice or ice water to drink, so that that area, the sensation with the nerves, it is slightly reduced, and by the time the effect goes, you can take the radiograph. So it should be again quickly, or you can ask the patient to rinse the mouth with some salty water, which you have to provide, of course, or put table salt on the tip of the tongue. So this confuses the sensory nerves and reduces the gag reflex. If the patient is still having a gag reflex, you cannot do anything else. Put a topical anesthetic, spray, or a gel which can numb that area, and you can take the radiograph after instructing the patient to exhale while the anesthetic is sprayed. Okay? If the patient inhales, the patient will swallow the anesthetic, and this will again create a bad experience for the patient because of the bitter taste of the anesthetic. Okay, and the topical spray, its effects goes away after 20 minutes, so you should be able to take the full mouth exposure during that time. If the topical spray is used, always ask the patient about any allergic to these anesthetics, especially to benzocaine. Okay, so these are the most common allergic inducing topical anesthetic that you can expect. So if he or she is allergic, use the other techniques for reducing the gag reflex. So, uh, mounting the radiographs, you have to remember that when you take the radiographic exposures and arrange it for the dentist, if you're using a film based radiography, mounting means you are going to take the identification dot into consideration. Okay, so the identification dot for the maxilla is down and mandible should be up. So the radiograph before exposure, it should be placed and radiographed with the same instruction. So when you take the radiograph in hand, if the occlusal dot to the crown is what you are going to match. So for mandible, you are going to see the anatomic landmarks as well, which will help you in the mounting. Okay. So for mandibular teeth, the teeth crown will be up and you will not see palate or nose in the mandibular teeth. Okay, so mandibular teeth has to be always arranged with the crown upside, occlusal dot raised portion uh, towards, facing towards you. Okay, like how this person is standing and the raised portion of the occlusal dot is facing towards the patient. Okay, so mandible, crown up, maxilla, crown down. In maxilla, you will find the structures like nose and maxillary sinus, which we will discussing at a later session. And then mounting can be of two types. One is called as a labial mounting and the other is called as a lingual mounting. Okay, labial mounting is the one that you commonly use. Okay, labial mounting in which the identification dot, the raised portion, is towards you as you see in this image. Okay, and in the case of lingual mounting, the identification dot, the raised portion, is always opposite to you. That means it will touch the view box which you are viewing. Okay, so these are the things that you have to remember when you consider mounting. Okay, so mount the films immediately after you process the radiograph. Clean and dry hands is the one that you require for mounting. Wet hands will make the film sticky. When you arrange the teeth in order, you'll be able to distinguish the right and the left side, maxilla and mandible. How to do that? We will learn along with the anatomic sections as well. Okay, so definitive order of mounting is required. First maxillary anterior periapical, then mandibular anterior periapical, then the bite wing which follows a small curve upwards. So premolars will be in the same line and for the molars, it will be slightly raised following the curve of Spee. Very important and asked frequently in your exams. Mounting biting radiographs are done with the curve of Spee. So, what is curve of Spee? It is the occlusal plane between maxillary and mandibular teeth. So, if you see the teeth or dentition, as you go back, the curve goes up. This is called as the curve of Spee. That is why we position the molar radiograph slightly up and the premolar slightly on the down in comparison to the molar. So the periapical will be arranged maxilla and mandible down, the bite wings in between, and up region to the bite wing you will have the maxillary posteriors and down mandibular. So your right side is always patient's left side. So when you arrange the film, you'll be arranging the left side of the patient in the quadrant. Okay, so this is your patient's left side and this is the patient's right side. So your hand, right hand, corresponds to patient's left side of the jaw. So when you start the arrangement, it will be first quadrant, second quadrant, third quadrant, and fourth quadrant. Right maxilla, left mandible, right mandible. Okay? So this is how you are going to arrange in labial mounting technique. In lingual mounting, your right will be patient's right, and the occlusal dot raised portion will be touching the view box.